The last single gene disorder that we'll discuss in childhood is achondroplasia. It's a form of dwarfism, more rare than some of the other single gene traits that we've talked about, but it is a short-limbed dwarfism, meaning the torso is normal, the head size is normal, although there are alterations in the appearance of the skull. But there's a mutation in a large gene for fibroblast growth factor receptor, and that gene is called FGFR3. It is inherited as an autosomal dominant disorder. So there are no carriers for achondroplasia. You either have it or you do not have it. Incidence is 1 in 15,000 to 40,000 live births. It occurs in all races and ethnicities, but about 85% of these are not inherited. They are from de novo mutations associated with advanced paternal age, which we'll talk about on one of the next slides. If you have 2 copies of this dominant gene, it is lethal. Very early in embryonic life, there will be perinatal loss. You have to have at least 1 normal copy of a gene. You cannot be homozygous for it. Okay, the pathophysiology. So FGFR3 makes a protein that is important in the development and maintenance of bone and brain tissue. It is the mutated protein, when we have achondroplasia, eats up fibroblast growth factor. It kind of takes it up, and so it can't be used in the body. And that means that long bone growth during embryonic, fetal life, and then later on in childhood is interrupted. And we have shorter femurs, shorter, all of the long bones are shortened. Some of the other bones in the body are affected, particularly the skull, so you'll see some facial differences. But there are 2 point mutations. There's 2 weak points in that large gene where it's more likely to get altered. And that causes 99% of achondroplasia. And what happens in those point mutations is that the base or the amino acid arginine gets manufactured instead of glycine. And so that protein just doesn't do its job. It ends up eating up all the fibroblast growth factors. Most of the cases are de novo mutations, and they are linked to advanced paternal age. And that makes sense if you think about it. Men are producing spermatozoa all through their lifespan. As men age, the telomeres on all their cells get shorter. Remember, telomeres are those little end caps on the ends of chromosomes that protect genetic material from changes. So as men age and create spermatozoa, there can be more damage at different points in the sequence of bases. Signs and symptoms of achondroplasia, generally you see the same intellectual potential. Brain development is not part of this disorder, although sometimes hydrocephaly can influence intellectual development. You see a slightly larger head size. It's called frontal bossing, and you can kind of see that in the picture on the bottom right, where the forehead is sort of pronounced. There is a normal sized torso, so all of the organs, they sort of develop normally, but you have disproportionately short extremities, and sometimes you see this on fetal ultrasound, and it's like a marker. If you have shortened femur length or, they usually do measure the femur on ultrasound. Creased skin in the extremities, very short neck with abnormal junction to the head, and this causes a lot of problems with breathing, including sleep apnea and obstruction. And there's a high incidence of sudden infant death syndrome, so we have to be really careful with infants who are diagnosed with achondroplasia. And it's pretty apparent on the newborn exam when you see those shortened limbs and the frontal bossing, but it would be, confirmed. Symptoms: large prominent face with that prominent forehead, delayed motor development because the short and long bones have to carry a heavier torso and head, shortened stature over time. The lower back, the lumbar spine will develop lordosis to balance the load of a heavier torso over smaller limbs. Crowded teeth with poor bite is common in this disorder because of the different development in the skull bones. And hydrocephaly, which is present in about 15% of the cases, we would treat that with a VP shunt, meaning we would create a way to drain fluid off the brain and into the peritoneum. Other things we can do, correct scoliosis if it's present. Leg lengthening is controversial. There is a procedure that exists, but it can be painful. It is time consuming, and there's a movement within groups of people with achondroplasia that want, people to accept and embrace the condition as just part of who they are. Surgical correction of hydrocephalus is very important if it's present. Again, that ventriculoperitoneal shunt, VP shunt, to get the fluid off the brain. And then, of course, supportive therapy like physical and occupational therapy to help that child grow and develop and achieve their milestones. Now, if both parents have achondroplasia, it's usually considered wise to seek the assistance of a genetic counselor and determine if they want to do pre-implantation genetic diagnosis and IVF to eliminate the risk of recurrent perinatal loss, because if both parents contribute that dominant allele, the embryo cannot develop. And so they might have recurrent perinatal loss early in pregnancy. Obviously, we want to treat obstructive sleep apnea to provide better quantity and quality of life. There may be surgery to decompress the cervical spine. As I said, that juncture of the head and neck is sometimes affected, and that can cause pain. Management of ear infections. So with the changes to the skull bones, you see smaller eustachian tubes. It's more difficult to drain. So in early childhood, ear infections are very common in kids with achondroplasia. So placing the tubes in the ears might be a treatment that's explored. And there are a lot of resources for people with achondroplasia. Again, these folks can have a normal lifespan, normal quality of life. There are reality shows that document sort of this journey that people have. If you were to do a Punnett square on two people with achondroplasia having children, you would see, I don't know if I have that here, I don't, but you would see that it is possible for two people with achondroplasia to contribute a recessive allele and have a child of normal stature without the disorder. So that's achondroplasia. It's about what you need to know for this course. There's much more that we could say about it, but I think that's good. We're going to move on with the discussion. Next topic will be complex polygenic disorders that are diagnosed in childhood, and the only two examples we will use for that are type 1 diabetes and asthma.